Hello, and welcome to another talk on the basic sciences. Here we're going to talk about purine metabolism, especially as it applies to the major disease which comes out of purine metabolism, where purine metabolism is important, and that is gout. So we'll start off with a vignette. We have a 57-year-old guy coming into the ED who complains of severe pain in his right foot. He was fine when he went to bed, but he woke up at about 2:30 a.m. with excruciating pain. He's tried ibuprofen, but the pain remains at a plus 10 out of 10. He denies injury, and this has never happened before. He works as an accountant. He denies smoking and drug use. He's monogamous with his wife of 25 years. He had 4 beers last evening while attending the football game, and he says that he usually has about 2 to 3 drinks per week, but he drank a little bit more than usual last night. Past medical history includes hypertension, which is controlled with lisinopril hydrochlorothiazide, very common drug given for hypertension. No past surgeries. Vitals are significant for blood pressure of 140/90, low-grade fever of 100.4, heart rate 115, respirations 14. So we'll look at his joint here, and his joint is like this. Is this normal? No, this is not normal. So here is the abnormality, and where is it? Well, it's in his big toe. And what do we call a big, swollen, red, tender joint in the big toe? We call that podagra. And podagra is one of the very stereotypic signs of gout. Now, does everybody with podagra have gout? No. But this is very, very common way that gout presents. About 50% of people with gout will have podagra. And podagra is just an inflammation at the first metatarsal phalangeal joint. The metatarsal phalangeal joint, you have 5 of them, and it's basically where the toe converges with the foot. Okay, so we'll get some basic labs. We want to get just a general workup. We get a CBC, chemistries, probably include liver function tests, and then a uric acid level. And what do we see? We see an elevated white count, an unremarkable chemistry, and a uric acid level, which is high at 10.4 milligrams per deciliter. So you might be looking at this and saying, well, gee, I don't know what he has. First off, he's got a temperature, and he's got an elevated white count. What does that look like? Well, that looks like septic joint. Could this be septic joint? Absolutely. This is all consistent with septic joint. On the other hand, you might be saying, well, he's got an elevated uric acid level, and he's got a swollen joint. That sounds like gout. Could this be gout? Well, it probably is because it's the name of our lecture, but yeah, absolutely. This could be gout. So how do you know the difference? And the fact is you don't. You don't know the difference. And so you need to do one more thing here. And what do you think that is? I'll give you a hint. It's sort of your mainstay of determining what the heck a swollen joint is. And that is an arthrocentesis with synovial fluid analysis. You're going to tap this joint and look at that joint fluid under a microscope, do some analysis of that fluid, and get a profile of it. You find out it's cloudy on gross appearance. Cells are 15,000 per cubic millimeter. 93% of the cells are PMNs. And then this is very, very important that you know this. There are crystals. Crystals aren't always there. If this were a septic joint all by itself, you wouldn't have crystals. But in fact, you do see crystals, and you need to know what kind of crystals they are. They're negatively birefringent needle-shaped crystals, and that is the crystals of gout. These are called monosodium urate, or MSU crystals. And you need to know they are negatively birefringent needle-shaped crystals. Now, if they were positively birefringent rhomboid-shaped crystals, this would be something totally different. But they are negatively birefringent needle-shaped crystals. That is consistent with the diagnosis of gout. The Gram-Stay and culture are pending, so can you totally rule out septic joint? No, but you know he does have gout. Okay, so this is consistent with the diagnosis of gout. Now, that whole uric acid level, why did we get it? Because we said, well, he's got an elevated uric acid level, but we can't say for sure he has gout. So why did we get it to begin with? Well, the fact is, a high uric acid level is consistent with gout. It's not diagnostic of gout. Okay, so if he has a high uric acid level, that tells us, yeah, he's probably got gout, but we don't know for sure. Okay, there are some people that have high uric acid levels. They don't have gout, but they have high uric acid levels. On the other hand, there are people with normal uric acid levels who have active gout. Okay, so this guy could have a normal uric acid level, but he could still easily have gout. Okay, so you can't rule out gout with a normal uric acid level, and you can't diagnose gout with a high uric acid level. All the uric acid level tells you is if it's high, it's consistent with gout. If it's normal, it's not necessarily gout, but it still could be gout. Okay? Any questions on that, please write me a note. All right? So this elevated blood pressure is probably just due to the fact he's in pain. The high heart rate, probably due to the fact that he's in pain. The high temperature and the elevated white count, you get that with gout. Okay, it's not unusual to have a fever and a high white count with gout. Okay, that does not necessarily mean septic joint, but you can't rule it out. Okay, those things happen with septic joint too. Okay, so just keep an eye out for that. So we're going to briefly talk about purine metabolism. Really, despite my biochemistry background from college, I'm going to try not to get into the nuts and bolts of this too much, but I want to point out some of the important things of purine metabolism. And then we'll talk about gout in some length, and then I want to talk about 2 other diseases that are important as far as this pathway goes. But you're not going to run into it too much on the test, but if you're taking USMLE Step 1, you do need to know these 2 diseases. So this is the purine metabolic pathway, and there's a few important subsets of this pathway: the synthesis of purines, the breakdown of purines, and the salvage of purines. So let's first start out with the synthesis of purines. Purines can all be synthesized by with a molecule called ribose 5-phosphate. Now, if you've listened to some of my lectures before, you may recognize ribose 5-phosphate. Where do we get ribose 5-phosphate from? What pathway? This is a major product of the pentose phosphate pathway. Pentose phosphate pathway starts off with glucose 6-phosphate, which is a product of glycolysis, and it shunts it off into a different direction. Ultimately, the products that come out of that pathway are going to go back into glycolysis or gluconeogenesis. But the 2 major products you get out of the pentose phosphate pathway are NADPH and ribose 5-phosphate. And ribose 5-phosphate is what makes purines. It's one of your way of making purines. So ribose 5-phosphate is going to get converted into PRPP, which I believe stands for like phosphoribosylpyrophosphate, pyrophosphate, but don't quote me on that. And then PRPP takes several steps. I think it's like 9 or 10 or 11. It's a lot. And that ultimately gets converted to IMP. Now, along the way, there are some enzymes that are important pharmacologically. Some that get blocked by sulfa drugs. Remember, the sulfa drugs are like antibiotics. And then another that gets blocked with methotrexate. And that particularly uses folate. And so sulfa is... These drugs are antibiotics, like sulfamethoxazole, and then methotrexate, that's used as sort of a cytotoxic drug, which we use for a lot of the autoimmune disorders. And so they function to sort of inhibit cell metabolism. Ultimately, what we get from this is a molecule called IMP. So IMP is kind of at the center of all of this. IMP is inosine monophosphate, and it can become a few different things. It can become GMP through an intermediate called XMP, or it can become AMP through an intermediate called adenylosuccinate. So GMP and AMP. GMP is guanosine monophosphate, AMP is adenosine monophosphate. And what those can become is the building blocks for RNA and DNA synthesis. Okay, so AMP and GMP can get phosphorylated to become ATP and GTP. That goes into RNA synthesis, and then you can reduce that and become deoxy-ATP, deoxy-GTP, and those are your building blocks for DNA synthesis. Okay, so you start with ribose 5-phosphate, you become DATP and DGTP, or ATP and GTP, and you can see how all of these things are important for RNA and DNA synthesis. They're your building blocks for RNA and DNA synthesis. Now, on the other hand, you can take AMP, IMP, and GMP, and you can break these things down. So let's say your body doesn't need this stuff. You don't need to be making RNA or DNA at a given point. And you can say, hey, I've got all this AMP, all this IMP, all this GMP, but I don't need it right now, so I need to get rid of it somehow. And so you can take that and you can break it down. And based on what you're starting with, AMP, IMP, or GMP, you break it down into different things. So with AMP, you can break it down to adenosine and then to adenine. With IMP, you break it down to inosine and then hypoxanthine. GMP to guanosine and guanine. Not so important you know what each of those are, but those are breakdown products. Now, all of this stuff is going to converge onto this pathway here. And the final product of this pathway is uric acid, ultimately. And as you know, uric acid gets excreted through the kidneys. But looking at this pathway, you can see that the products of AMP and the products of GMP both converge onto this pathway. So with AMP, it's adenosine, which gets converted to inosine. IMP goes directly to inosine. And then with GMP, it's guanine, which gets converted to xanthine. And all of those things, inosine and xanthine, they both ultimately will go to uric acid. So the process of taking adenosine and going to inosine, there's an enzyme that catalyzes that process, and it's called ADA, adenosine deaminase. And there's something that blocks that called cladribine. And cladribine is a chemotherapy drug. And the reason that this works is ultimately it's going to reduce DNA and RNA synthesis. Well, how does it do that? It does that because if you block adenosine from becoming inosine, you're going to block the amount of inosine that becomes hypoxanthine, and hypoxanthine is a product that ultimately can go back into IMP and then back to AMP and GMP and ultimately go into DNA and RNA synthesis. So that's how that works. Talk about that in more detail in a little bit. Now, when you get down to adenine, hypoxanthine, and guanine, there's a couple ways you can go. Okay, you can go towards excretion, or you can go backwards. If you're going backwards, and that's very useful to you, going backwards, you can take these products, which may come from your diet, and you can take these products and go back to making RNA and DNA. And that's called salvage. So what you're doing is you're taking either adenine, hypoxanthine, or guanine, and you're taking this PRPP. And this PRPP, all it is it's a phosphate group attached to a ribose, and then 2 phosphates on that. And what you do is you take the phosphate ribose part of PRPP, you attach it onto your base, either adenine, hypoxanthine, or guanine, and then what you have now is a base with a phosphate and a sugar on it. And that's the AMP, IMP, or GMP. And then the byproduct of that is going to be the pyrophosphate part. So now you have AMP, you have IMP, you have GMP, and you can use that into making RNA and DNA. That's called salvage. You're taking, instead of getting rid of it, you're taking it and using it. You're salvaging it and going into RNA and DNA. So the 2 enzymes that are important for salvage are APRT, which you don't need to know for our purposes here, but this very important enzyme called HGPRT. And that is your enzyme that you use both for taking hypoxanthine and going back to IMP, and guanine and going back to GMP. If you don't have that enzyme, you cannot salvage. Okay, so if you're not going to salvage, then ultimately you're going to converge on this pathway here, this degradation pathway. And a very, very important enzyme in the degradation of purines is called xanthine oxidase. And xanthine oxidase is what converts, it does 2 steps. It takes hypoxanthine and converts it to xanthine, and it takes xanthine and converts it to uric acid. Okay, so this is xanthine oxidase. And ultimately what it does is it makes uric acid. And uric acid you can get rid of through your kidneys. All right? So this is the purine metabolism. And you don't need to memorize all of this, but you do want to know these 3 enzymes, ADA, HGPRT, and xanthine oxidase, what they do. And then it's useful to know, have an idea of what salvage is and why it's useful to you. And then some of these drugs, so the sulfa drugs and methotrexate, Why they work? Well, they work by reducing your ability to do RNA and DNA synthesis, either through sulfa drugs, and the sulfa drugs are doing that by blocking folate synthesis, so that's how that works. Methotrexate, it's cytotoxic. You're reducing your ability to make RNA and DNA. That's why it's used for autoimmune diseases. Mycophenolate, this is a drug that essentially functions very similarly to methotrexate in that it's cytotoxic and you're reducing your ability to make RNA and DNA, but it works at this particular step. So it reduces your ability, if you're starting out with ribose 5-phosphate, reduces your ability to make GMP. So if you're not making GMP, you can't make DNA because you need some of those guanine base pairs. And so if you can't make the GMP, then you can't successfully make the DNA you're supposed to. And so mycophenolate is a drug that is used for transplant to prevent transplant rejection. Very commonly used for that purpose. Clodarabine, I believe we talked about. And then the xanthine oxidase inhibitors. You can imagine what that does. If you inhibit xanthine oxidase, you reduce the amount of uric acid that's going to be in your blood because you block the production of uric acid. Okay, so we'll come back to some of this in a little bit. So if you have a high uric acid level in your blood, it can be either primary, meaning it just comes from your normal metabolism, or it can be secondary, meaning it comes from a disease process or a drug. So with primary hyperuricemia, it's coming from one of two things. Either it's just your body's way of doing it, and that's just how it is, or it's from an enzymatic defect, which is sort of your body's way of doing it, but there's a defect to the way your body does it. Okay, so increased purine production can be either from an enzymatic defect, or it can be idiopathic. One of these enzymatic defects we'll talk about in a little bit. Or you can have decreased renal uric acid clearance. These are patients that for one reason or another, they just don't get rid of uric acid through their kidneys as they should. And these are patients that are going to be predisposed to gout. With secondary hyperuricemia, there's some kind of other disease process going on, or some drug that they're taking, and it's reducing their ability to either get rid of uric acid or it's increasing the amount of uric acid that's getting spilled into their blood. So with increased purine turnover, basically what you think about here is you have cells that are dying. Okay, cells are dying and they're spilling out all their content. And what are cells full of? They're full of DNA and RNA. And if your cells are spilling their contents into your blood, well, then you're going to have high uric acid levels in your blood because that's one of the breakdown products of DNA and RNA. So anything that increases cell death or increases cell production and then subsequently cell death is going to cause hyperuricemia. So myeloproliferative disorders, lymphoproliferative disorders, carcinoma and sarcoma, all of these things increase the amount of cells and then cell breakdown. Chronic hemolytic anemia, cytotoxic drugs by killing cells and causing them to spill their contents, and then psoriasis. And that's because of increased cell turnover. And then decreased renal uric acid clearance. What would do that? Well, certainly kidney disease would do that. Why does kidney disease do that? Well, because your kidneys can't get rid of the uric acid because they're not working. And then tubular transport impairment. So that can be due to drug factors. Diuretics are a big one that will reduce your uric acid clearance. Hyperlactic acidemia. Why? Because lactic acidosis, you're going to get rid of that lactic acid if you have lactic acidosis, because lactic acidosis can kill you. Uric acidosis, not so much. So if you have lactic acidosis, body's number one priority is to get rid of lactic acid. Well, it just so happens that the route lactic acid takes to get out of through your kidneys is the same that uric acid takes to get out. But your body is going to prioritize getting rid of lactic acid. So if you have high lactic acid, for that lactic acid to get out, it's got to go through the kidneys, and it's blocking the door for uric acid to get out. And so uric acid will accumulate if you have high lactic acid. Hypoketoacidemia, and then diabetes insipidus and Bartter syndrome. Okay, you can look those things up on your own. I believe that should say hyperketoacidemia. Okay. Okay, so gout. This is how an artist depicted gout. Gout is a very old disorder. We've known about it since the ancient Egyptians. They even knew about its association with the great toe. So this is an ancient disease. We've known about this for a long time. Even Hippocrates noted that gout is rare in women for one reason or another. And then the Roman physician Celsus, back in the 1st century AD, he noted that it's associated with alcohol. So we've known about gout for a long time. Very, very old disorder as far as our knowledge of it goes. Gout is characterized by acute painful joint inflammation due to urate crystalline deposition in the joint fluid. It can also get deposited in the skin. So this is these monosodium urate crystals. All they are crystals that form in the joints. Now these crystals can form elsewhere. You can get crystals that form in the kidneys, and that's a way you can get kidney stones. But as far as gout is concerned, these are crystals that form in the joint fluid and cause an inflammation. Now there are primary gout versus secondary gout, and really that just goes to the same as far as primary hyperuricemia and secondary hyperuricemia. Okay, so primary gout is just gout that it's kind of like idiopathic gout. Okay, it just develops in a person. Okay, no cause behind it, just develops, and that's very common. Okay, most people, there's not a reason for their gout, they just develop it. And what it probably has something to do with is that they just don't have, intrinsically, they either make too much of these products which go into uric acids, they're making too much uric acid, or for one reason or another, just genetically, their kidneys don't get rid of uric acid as efficiently as other people. Okay, so that's primary gout. Secondary gout is associated with some kind of acquired hyperuricemia, so some kind of secondary hyperuricemia. There's some medications that can predispose to it, so things like diuretics, aspirin, cyclosporine, niacin. Why aspirin? Probably because aspirin can cause a slight lactic acidosis, and that might compete with some of the uric acid getting out. Not sure about that, 100% sure about that. Cyclosporine and niacin, not sure at all how those do it. But diuretics, low-dose aspirin, cyclosporine, and niacin. Some conditions, myeloproliferative disorders. We talked about that. Multiple myeloma. All these things are cells getting into your blood and then breaking down ultimately. Chronic kidney disease. That's going to reduce your ability to get uric acid out. Hemoglobinopathies. Again, you're making cells. These cells get broken down. Essentially, these are hemolytic anemias. Hypothyroidism, psoriasis, sarcoidosis. Okay, so these are this is secondary gout. And then there's risk factors for gout. Things like lifestyle. We know that people who are obese have a tendency to get gout. Diet. The more meat you eat, higher your risk of gout. Alcohol use. And then age and genetics. Okay, so older people are going to get gout. I believe the average age for gout, or at least the highest incidence, is in the 8th decade of life. So men in their 70s have a high incidence of gout. And then as far as genetics go, it just tends to run in some families. There's an increased incidence in African Americans. There's also an increased incidence in Pacific Islanders. And then I should have put here that sex is also a risk factor, not having sex, but your gender. So men are far more likely to get gout than women. About 85% of patients with gout are men. And the few women who do get gout, typically it's going to be some kind of secondary gout. All right. So classically, gout presents as a sudden onset, severe inflammatory monoarticular joint pain. What does that mean? Well, it comes on suddenly, so it's acute. It's not like RA where you have joint pain all the time. It's severe. Kind of can contrast that a little bit with osteoarthritis. Osteoarthritis, the patients will not typically describe it as a 10 out of 10. It's going to be kind of an ongoing, mild to moderate joint pain, and a lot of times ibuprofen will help. It's inflammatory. So what's not inflammatory? Osteoarthritis, not inflammatory. Osteoarthritis is painful, but it's not going to be red and warm and swollen. This is inflammatory. Get a big, ugly, red, hot joint. And it's monoarticular. Okay, it tends to only affect one joint at a time. Okay, so it can be in multiple joints. Okay, so just because it's in 2 or 3 joints doesn't mean it's not gout, but classically gout is going to be in one joint at a time. Okay, so sudden onset, severe inflammatory monoarticular joint pain. Around half of cases are going to be podagra, and occasionally other joints are involved. Usually it's going to be things like the ankle or the knee or the joints in the fingers or hands or wrists. Very rarely is it going to be the big joints like the hips and the shoulders. The pain that comes from gout is abrupt. It comes on very suddenly, and it tends to worsen over about 8 to 12 hours, and it'll persist for a couple days if it's not treated. Ultimately, though, it will go away on its own, but patients will come in to see you before letting it go away on its own because it is exquisitely painful. Other features. So you're going to have cardinal features of inflammation overlying the joint, so much to the point where it can get confused with cellulitis because the skin is just ugly looking. It's red and it's warm and it's swollen, and so it looks a lot like cellulitis. But it's going to be joint pain. Fever is not unusual, not all the time, but if you have a fever, you don't immediately think that it has to be an infection. Okay, so if you have a fever, that's totally consistent with gout. It does not mean you have an infection. And then the presence of these things called tophi. And tophi are just hard uric acid deposits beneath the skin. Kind of like xanthomas are to cholesterol, tophi are to uric acid. Okay, so this is gout. Again, podagra. You have gout and the first metatarsal phalangeal joint. Again, same thing. This is such a common place to see it, so I put a lot of pictures on here for you. And you can see, oh look, this is in a woman. Okay, not common for women to get gout, only about 15%, but can happen. Or, it might be a man who likes to paint his toes, but this is probably a woman. All right. Okay, you can see it also can happen in the finger joints as well. So you can see here it's happening in the knuckles, metacarpal phalangeal joints. Okay, so you can see here. And here it is in 2 joints. Not as common, but it does happen. And this is an acute episode. Look how red and swollen these are. Okay, now these are tophi. So if you look at the overlying skin, it's not red and swollen. These are just big nodes and nodules. And you might think of it and think, well, these look like the Heberden and Bouchard nodes that you get in osteoarthritis. And it can be difficult to tell the difference between the two, and so I don't expect that you're going to get a test question and it's going to just say, what is this? It'll give you a history. But in general, tophi are a little bit bigger than those Bouchard and Heberden nodules. Okay, so again, nodes. These little nodes here. These are tophi. They also tend to be very hard. They're very, very hard. They almost can feel like little bones, just where they shouldn't be. Okay, so you can see here, these are a little bit more obvious, but they're smaller tophi, but they're a little bit more obvious because they're under the skin. So you aren't going to confuse these with Heberden and Bouchard. It's also the location helps too, but you can see they are precipitating underneath the skin. Okay, and you also get them on the helix and pinna of the ear. They can also be really, really big and deforming. So this is obviously a patient who just has not been treated well at all for his gout. So you can see some of them are collecting around the joints, some are just over the skin. So the 2 most important differentials of gout are cellulitis and septic arthritis. Why are these 2 important? They're both infections. And if you don't treat them properly, the patient can die. Okay, you go from cellulitis And especially septic arthritis, you can go to just plain sepsis very easily if you don't treat it. So you want to know whether it's cellulitis and septic arthritis or if it's gout. And so getting your workup will help you do that. Now, cellulitis, typically, all your joint workup is going to come back negative. But with septic arthritis, there'll be one particular feature which we'll talk about. Okay, so our workup, we already said CBC, CMP, uric acid. And then in our arthrocentesis. And how is this going to come back? CBC will tend to show increased white counts. CMP can be variable. Remember that some patients with gout have renal dysfunction as a secondary cause of their gout, so that may show up. Uric acid, elevated 90% of patients, but a normal uric acid level does not exclude it. Arthrocentesis with synovial fluid analysis, the appearance tends to be translucent to cloudy, viscosity is low. Cells can be all over the board, but they tend to be high, very high. They're never normal. PMNs are usually more than 90%, that's very high. Crystals, negatively birefringent needle-shaped crystals, got to know this for the test. Gram stain culture, pertinently negative. Okay, so all of this looks very much like, this arthrocentesis picture looks very much like septic arthritis, with the exception that you have these crystals and that the gram staining culture is negative. These two are what's going to help you differentiate. The rest of it looks quite similar to a septic arthritis picture. Okay, we're not going to talk about all these, but these are some of the arthritis causes and how the synovial fluid analysis comes back. So we have osteoarthritis, we have some of our autoimmune arthritis, rheumatoid arthritis, psoriatic arthritis, reactive arthritis, gout and pseudogout, and septic arthritis and a hemarthrosis. And you can see here, the difference between gout and septic arthritis is primarily going to be the crystals. We have crystals in gout, you don't in septic arthritis, and the culture. You have a negative culture in gout and a positive culture in septic arthritis. Now, what if you have crystals, negatively birefringent needle-shaped crystals, and a positive culture? That can mean one of two things. Either your sample got contaminated, or you have both gout and septic arthritis. But if you have a positive culture, you're going to be treating the patient with antibiotics. Okay, you're not going to say, oh, well, it may have come back, it may be contaminated, and so I don't think I'm going to use antibiotics. Septic arthritis is a big MFing problem. All right, so you need to treat that. You have to treat that. If the culture comes back positive, you're going to be treating that. Okay, but if you have crystals and a negative culture, that's a diagnosis of gout. Even if you just have crystals, you're still going to treat gout because that patient still has gout, no matter how the culture comes back. Okay, the question is, if the culture comes back positive, yes, you've got to treat septic arthritis. Okay, so how do we manage gout? This is going to come up on the test. They're going to ask you what's the best first step in the management of this patient. And the answer for gout is that you give them an NSAID. Okay, all other things being normal. There are some patients who can't have NSAIDs, then you do something else. But for the vast majority of patients, all other things being normal, they get NSAIDs. Why do we give NSAIDs first? Well, you have a patient that's writhing in pain. Your first step is to treat their pain. Okay, you got to treat their pain. As long as they're vitally stable, you got to treat their pain. Okay, and this is much easier in real life when you have a patient that's, throwing stuff at you and telling you, I need something for my pain. You think, okay, treat their pain. But when you get a test question and you don't have that patient in your face, you might go off and think, well, I'm going to give allopurinol. No, you got to treat their pain. Okay, so NSAIDs. And here I'm not talking about ibuprofen, I'm talking about prescription strength NSAIDs like Indocin, Ketorolac, things like that. Indomethacin is the classic drug given for gout, but other NSAIDs are fine too. Alternative agents. So let's say the patient has peptic ulcer disease. Well, what can you do in that case? You can do a COX-2 inhibitor. Functions the same way as an NSAID, but we try to avoid it because of its cardiac issues associated with it. Or you can do colchicine. We try to avoid colchicine because of GI side effects. Really nasty diarrhea comes with it. So colchicine we typically reserve for people who can't tolerate NSAIDs. You can also do corticosteroids. Here's the problem with corticosteroids. If you haven't already ruled out septic arthritis, you cannot give corticosteroids because you will cause them to become very sick and die. Okay, so if you've ruled out septic arthritis, go ahead and give corticosteroids, but it is still a second-line drug. NSAIDs are first line. But certainly, you need to rule out septic arthritis. You need to have a negative culture in gram stain before you can give corticosteroids. Once the pain is managed, your next step is to determine whether they are an under-excreter or an overproducer of uric acid. And the way we do this is to get a 24-hour urine uric acid level. Now, what does this mean, under-excreter, overproducer? Remember, there's two ways you can be hyperuricemic. Either you don't get rid of enough uric acid and therefore it accumulates in your blood, an under-excreter, or you're just making too much uric acid and you have too much uric acid in your blood. You're overwhelming your kidney's ability to get rid of uric acid. That would be an overproducer. So what you get is this uric acid, this urine uric acid level over the course of 24 hours. If it's less than 800, what that tells you is that the kidneys are not getting rid of uric acid as quickly as they should. Okay, so these patients don't excrete uric acid like normal people, and that's what's causing their uric acid level to be high. These are under-excreters. If their uric acid level is high and their urine uric acid level is also high, what that's telling you is the kidneys are doing exactly what they should. They're getting rid of more uric acid than normal kidneys, but their kidneys are they're trying to keep up. So they are doing what they should. The problem is that they are making too much uric acid. So these are the overproducers. Okay, so some people will be under-excreters, some people will be overproducers. Most patients are under-excreters. 80% of patients are under-excreters. Okay, so once you know that, then your next step is to prevent subsequent episodes, basically giving prophylaxis for gout. All right, and you're going to do that right off the bat. You're going to do that with all patients who've ever been diagnosed with gout. So if they're overproducers, you have one choice, and that's the xanthine oxidase inhibitors. That's things like allopurinol. That's going to be the one that comes up on the test. There's another one, brand name Uloric, and it's febuxostat. That's the generic, but it's Uloric. You'll hear that in the commercials. Here in the U.S., we advertise our drugs on TV. It's kind of nice because you'll remember the brand names that way, but some people don't like the fact we do that here. If you're an under-excreter, you have two choices, okay? So with overproducers, you only get one choice because the kidneys are working fine. With under-excreters, you can kind of nudge their kidneys to get rid of uric acid and kind of boost their kidneys a little bit. Or you can just do xanthine oxidase inhibitors. So you have two choices. You can give the xanthine oxidase inhibitors. That works by reducing your production of uric acid. Or you can give what's called uricosurics. All that means is it increases the amount of uric acid that your kidneys are getting rid of. The two drugs that are uricosurics are probenecid and sulfenpyrazone. Okay, but what's the major caveat with that? Well, their kidneys have to be working. Okay, so if these patients have chronic kidney disease, you cannot give uricosurics. It won't work. What's the other caveat with that? Well, if they've ever had uric acid crystals, can't do it. No uricosurics if they get kidney stones, if they get uric acid kidney stones, because this is going to make kidney stones all the more likely. Okay, because you're getting rid of more uric acid through the urine. Okay, and if they have a predilection for uric acid kidney stones, then you cannot give these drugs. Okay, so for that reason, xanthine oxidase inhibitors just tend to be the drugs we go to. Some doctors won't even do the 24-hour uric acid level. They just go straight to allopurinol and just end it at that. But probenecid and sulfenpyrazone, these are options that you can give. And since 80% of patients are under-excreters, if for some reason they can't tolerate allopurinol or febuxostat, then these are drugs that you can go to. But probenecid has largely been, and sulfampurazone I've never seen in my life, but probenecid has largely become a sort of second-line drug for gout prophylaxis. And then lifestyle modifications. That's diet, exercise, weight loss, and avoiding alcohol. Those are all risk factors. Okay, so this is how gout can happen. They're either under-excretors or over-producers. And you can see all of these things, what you can do for them. Xanthine oxidase inhibitors for people who are overproducers, xanthine oxidase inhibitors, or uricosuric agents, or both, for patients who are under-excretors. This is the diet for gout, so we want a low purine diet. For the most part, you can eat quite a few things. The things you really have to watch, though, are meats. Okay, so meats pretty much need to be avoided. A lot of these patients are going to be eating small amounts of meat or no meat at all. If you're already a vegetarian, then your diet's going to be pretty good. The only thing as far as non-meat foods that you really need to avoid are things like beer and alcohol, and then you want to avoid some of the more whole grain, higher protein breads and cereals. So things like oatmeal, whole grain bread, brown rice, sort of grains that have more protein in it. Things like pasta and white rice and white bread, like Wonder Bread, totally fine. But if you're talking about like whole grain bread and brown rice, those are going to be a little bit higher in purine. They can still eat those, they just have to watch it a little bit more. But if you're talking things like apples and cheese and soda and coffee and popcorn, all those things are fine. Fruits and juices are good. Basically what you need to tell these patients, you can send them home with stuff that tells them, this is the kind of diet you should have if you have gout. But all they really need to take home is avoid meats, really limit your meats. If you do eat meats, make sure they're lean, and then try to keep otherwise to a high fruit and vegetable diet. Okay? But you can set them up with stuff to go home with. You don't need to memorize this. All you need to know, as far as test-wise, is avoid meat. Okay, so now for our special feature, we have a couple diseases that are relatively low yield for step 2 and 3, but very high yield for step 1. Although you don't need to know a whole lot about it because you don't need to know how to manage it. So a 3-year-old special needs boy comes into your clinic to establish care. Family is immigrants and they have not received regular care previously. He has a history of behavioral issues and is confined to a wheelchair and has never been able to walk or crawl. He does not speak but cries and screams on exam. Physical exam reveals hyperreflexia, spasticity, and lacerations and deformities of the lip and fingers. So this is a lot of times how USMLE questions come up. Don't give you a lot of information, but you'll want to know some of the pertinent features. So what is this? Write it down because we're going to talk about the next one. 5-month-old baby girl was brought to the ED because of decreased intake, emesis, and watery diarrhea for the last 4 days. She was seen here yesterday for the same and diagnosed with quote-unquote stomach flu and given IV fluids. Symptoms have persisted. Vitals are significant for hypotension and tachycardia. Review of chart reveals a history of thrush and pneumonia. She was at the 35th percentile at her 2nd-month checkup, but measures at the 10th percentile for length and 7th percentile for weight today. Physical exam is significant for ill-appearing infant and hyperactive bowel sounds. X-ray reveals absent-thymic shadow and rachitic rosary. Okay, so the first kid, what's he got? Behavioral issues. He's got some neurologic problems, hyperreflexia, spasticity, and he's got these weird lacerations and deformities on his lips and fingers. How does that fit in? Right? Well, if I told you that he has self-mutilating behavior, you would automatically know this if you've been studying for step 1, and that is that he has Lesch-Nyhan syndrome. Lesch-Nyhan syndrome, self-mutilating behavior, pair those two together, because if the USMLE tells you self-mutilating behavior, presto, you know what he's got. And I say he because this is an X-linked disorder. Okay, what about this second baby here? 5 months old. What's the big problem here? Well, first of all, history of thrush and pneumonia. Is thrush common? No. Pneumonia common? Well, maybe, but when it's in the presence of other infectious-looking processes, you got to take it into greater consideration. And this whole watery diarrhea issue sounds a lot like an infection, like some kind of gastroenteritis. So put all that together, along with the fact that she's dropping in percentiles, looks like failure to thrive with some infections. These infections span the breadth of both B-cell and T-cell related issues. And so this is SCID, SCID, severe combined immunodeficiency. But in particular, if you are really, really good and you know your 99th percentile stuff, this rachitic rosary, ADA deficiency. Okay, so if you guess SCID, you probably will get this question right, because the two most common types of SCID are X-linked SCID and ADA deficiency. And since it's a girl, it's not going to be an X-linked disorder. So it's going to be ADA deficiency. There's other types of SCID, but you're not going to get it on the test. You won't. Okay, so where do these fit in? Well, Lesch-Nyhan syndrome is a defect of that HGPRT, which you need for the salvage of these purine bases. Now, the problem is not so much that they can't salvage the purine bases. That's not really incredibly important. It's useful to you, but it's not critical. The problem is going to be because they can't salvage these bases are they're going to have excess bases going into becoming uric acid, so they're going to be hyperuricemic. Now, a lot of the symptoms from Lesch-Nyhan syndrome, we don't know where they come from, but we do know the symptoms, and they're very characteristic, and so you will get this on the test. But what you do need to know, Lesch-Nyhan syndrome, self-mutilation, Lesch-Nyhan syndrome, hyperuricemia, Lesch-Nyhan syndrome, X-linked recessive. It's only going to be boys with this. Okay, so this is a defect of HGPRT, which is a key enzyme in the salvage of purine bases to reform purine nucleotides. The problem is not that they can't salvage, the problem is that they get a buildup. And a buildup in particular is going to be PRPP and purine bases. Those purine bases then get broken down into uric acid, and they're going to have excess uric acid. It's an X-linked recessive disorder, typically presenting in the first year of life, failure to reach motor milestones, some hypotonia involved too. Now, you have a hypotonic baby, and then they become sort of spastic, not reaching motor milestones. What does that sound like? It sounds like cerebral palsy. And a lot of these patients with Lesch-Nyhan syndrome get misdiagnosed as cerebral palsy early on. And they look like cerebral palsy. But there's some key differences. First off, they may have this orange sandy material in the diaper. What is that? That's from the hyperuricemia. Then also behavioral issues, intellectual disability. Are patients with cerebral palsy, do they have intellectual disability? Not a lot. A lot of them are normal intellectually. Lesch-Nyhan syndrome, intellectual disability. They'll also have some degree of growth retardation. HENT, they'll tend to have these lacerations of their lips and oral mucosa. That's the self-mutilating behavior. That's a behavioral issue. Okay, they don't have any problem of their oral mucosa. This is all behavioral issues. They can get to the point where it's just defigured because of scarring. Extremities, they may show manifestations of chronic gout, like tophi. More commonly, though, what you're going to see in the extremities is their fingers are going to be all screwed up because they're constantly gnawing at them. Neurologically, you can see impaired motor function. A lot of this, though, neurologically, the picture looks like a combination of Huntington's disease and cerebral palsy. So they'll have the chorioathetosis and bulismus that you see in Huntington's, as well as some of the psychiatric issues. And then hyperreflexia, ankle clonus, things like that are more kind of the picture of cerebral palsy. So they've got these neurologic manifestations that kind of look like a combination of the two of them. Not exact, but roughly speaking. And then psychiatric issues, this is what's going to help you differentiate this from cerebral palsy. So self-mutilating behavior, compulsive behaviors, a lot of sort of almost like tic issues like Tourette's, but you'll see this these psychiatric issues as well. Testicular atrophy, delayed puberty, usually the patients aren't presenting that late, but these do come up too with Lesch-Nyhan syndrome. Self-mutilating behavior. Every question I've ever seen on Lesch-Nyhan syndrome on licensing examinations are going to give you self-mutilating behavior. So if you know that, you're good to go. Okay, this is Lesch-Nyhan syndrome. You can see these patients are all boys. They're all in. They look like restraints, but they really function both to help with their posture and to also help them so they don't chew on their hands. You can see these self-mutilating issues going on. You see the lips and you can see the fingers. So they're the common places they go towards. You can kind of see this abnormal sort of posturing. That's due to their neurologic issues. These happen to be twin boys, both affected with Lesch-Nyhan. Diagnosis based on family history. So mom, look for her to have male relatives, brothers, with Lesch-Nyhan. Patient history and lab findings. Really not a whole lot to see on labs. Hyperuricemia is really the big one. Again, you're not going to see that in cerebral palsy. Definitive diagnosis is an enzymatic assay looking for that HGTRT enzyme activity. Management, not a whole lot we can do. There's no cure. We want to control their uric acid because they will have very high uric acid levels, and we don't want them to develop stones because that can lead to chronic kidney disease. So allopurinol and hydration. Supportive care is really just focused on the behavioral therapy and helping them get semi-mobile so they can kind of have a normal life. Wheelchair fitting, protective devices to keep from the self-mutilating issues, and then behavioral therapy. We don't give them antipsychotics unless they're having really severe behavioral problems. We want to avoid that because of the side effects. Consultations, there's going to be a lot of them. A lot of these patients will just go off to specialized centers. Prognosis, there's no cure. Most of these patients will live to adulthood, but very few survive past 40 years of age. And the problems that they encounter that are going to lead to sort of death is going to be chronic kidney disease and aspiration because of their neuromuscular problems. ADA deficiency is a deficiency of the enzyme adenosine deaminase, which is necessary to convert adenosine to inosine for purine degradation, but also really the big problem is not that they're not making inosine, because you can get inosine through other directions. Okay, so going back here, you can get inosine naturally. I mean, normally you can get it just through synthesis of ribose 5-phosphate all the way to IMP and then go to inosine. So the problem is not that you don't have inosine, you're not making inosine. You do. You have plenty of inosine. Problem is that you can't convert the adenosine to inosine. You hit a dead end here. So you go to AMP, and all you can do with the AMP now is degrade it to adenosine, degrade it to adenine, and then salvage it to AMP, but you have no way of getting rid of any of that excess AMP, adenosine, adenine, because you can't get that out to uric acid. So what you're going to have is excess adenosine, excess adenine. The adenine can then go all the way to DATP, but then that DATP it can go into DNA synthesis, but the problem is DATP is an allosteric regulator of ribonucleotide reductase, which is the enzyme for DNA synthesis, and so you're ultimately going to inhibit DNA synthesis. Even though you have tons and tons of DATP, it's going to reduce DNA synthesis, and you need to incorporate other nucleotides into DNA. So just that allosteric feedback inhibition, so to speak, that's going to block your ability to make DNA. And then there's also the issue that adenosine is cytotoxic. So here's the two problems. Absence of ADA is going to result in accumulation of DATP, which allosterically inhibits ribonucleotide reductase and reduces DNA production. And then another big problem is that you have an accumulation of adenosine, which promotes apoptosis in very large quantities. So because B cells and T cells are very mitotically active, Disorders in DNA synthesis, accumulation of adenosine is going to dramatically affect their numbers. Okay, the other cells can get by, but B cells and T cells are the first to be affected. Similar to like when you give chemotherapy drugs. What are the first drugs that are affected? It's going to be the bone marrow cells, creating B cells and T cells. And so it's the B cells and T cells that are going to be dramatically reduced in numbers. This is autosomal recessive, affects boys and girls all the same. It presents as SCID in the first few months of life, but it's really going to be, if you don't, I mean, some of the features like that rachitic rosary and issues with their bones and cartilage, if you don't see that, if you work up the SCID, you're going to, you'll find the ADA deficiency. But if you get a test question and it tells you rachitic rosary in the setting of SCID, you know it's ADA deficiency. But for the most part, like I said, if you have a patient with SCID and it's a little boy, it's probably X-linked SCID. That's the most common cause of SCID overall. But if it's a little girl, it's definitely ADA deficiency, okay? Because they just don't get X-linked disorders. History will usually include thrush, pneumonia, diarrhea. That's all SCID. ADA is going to be no T cells, no B cells, no natural killer cells. That's unique. Distinguishing features: the rib cage abnormalities, chondro-osseous dysplasia. So, history of recurrent infections plus an absent thymus, you've got to think SCID. The differential for SCID, lots of different things. I bold-faced the ones you want to know for USMLE Step 1. Step 2, probably not going to get questions on SCID, but you might, so you want to know these two. So X-linked SCID and ADA deficiency. If it's a boy, think X-linked SCID, but it could be ADA deficiency. If it's a girl, ADA deficiency all the way. PNP deficiency. PNP is another enzyme that is actually involved in the purine metabolic pathway, but it's not so much important because it's so rare. But I just wanted to point that out because it is involved in that pathway. The only other one that theoretically could come up on the test is Omenn syndrome. I've seen it in review books, but I've never actually seen it in test bank questions. So you might want to just read over it, but these two are the only SCIDs that I've ever seen come up on test questions. The management for ADA deficiency, as with other types of SCID, you can do HLA identical stem cell transplantation, bone marrow transplant. Okay, if you have any questions, write me a note. Otherwise, I hope this will be helpful and useful for you. I think it will. But like I said, write me a note if you have any questions. Covered some pretty complex information here.